Okay, cool. So hello, good morning. Good morning, everyone. Welcome to today's community call. So for today, we will first again go through the Odyssey news, also our APAC news, and then most of all, we will do a Phenotype February recap. As now we're in March, and then there has already been 28 phenotypes and one bonus phenotype. So there are 29 phenotypes that were discussed throughout the months with everyone involved in Odyssey community. So today we'll be kind of watching two parts of the recap on what has been discussed on the 29 phenotypes during the February. So with that, we'll first kind of really discuss general Odyssey news. So we have, so as some of you may have heard, so there is a Darwin initiative that's gonna kind of really been initiated by the Medicine Agency. That's gonna really a big win for Odyssey community, that there will be kind of more and more sites from Europe that's gonna join our journey to convert their data in OMAP, and then we can have kind of the same analytics or the phenotypes that we're talking about, but with more data. So definitely exciting news. And then also, as for I know COVID, it's again COVID. So there has been different studies, and then this one is about a prediction model. Kind of not only we can do obviously characterization and treatment pathway for all of the COVID patients, but this is kind of a more novel or new ways that we could really study OMAP data and actually using a prediction model on top of all of the other analysis we have done previously. So feel free to take a look, and everything is under odyssey.org/news. So that's kind of for the Odyssey news, and then I would like to also share a news, kind of really odd, not sure about news, but really acknowledgement. Sorry, let me start share my window. That is here. So as you may know, this is the site we always go to, and we do have a APAC specific APAC community call specific page, just /APAC, and we kind of been posting all of the all of the past events and everything, kind of the chapter information. And here we also added a new link that we really want to say the appreciation and acknowledgement of the APAC study liaisons that are from the different regions in APAC community. So I won't go through all of the names one by one, but again, thank you so much for all of your support. Without you, I think there are the 4 studies, and we're really hoping kind of with the help, and we can all learn from the different studies throughout the year. So thank you so much for all of the help that we really appreciate it, and think there are definitely a lot of more learnings and also collaborations going forward in 2022. So great, a big thank you to all of you. So just go back to the page. So we will be kind of keep this page up to date with kind of the future community calls, and we'll be adding kind of the study information to it as well. And of course, all of the previous community call recordings are just listed here. So if you want to have a replay or anything, all of that is available here. So any questions or comments before we move to the phenotype recap? Cool. So with that, we'll first kind of go through the phenotype recap for update number 3, which includes, so if we go here, which includes a disease that we're at, one of the our 4 APAC studies are going to be about MS. So from that, we'll go through the update here, and hopefully this all be very informational to all of you here. So please let me know if the video is all good.
Just facilitate the conversation for us to have another weekly update on our Odyssey Phenotype February activities. This week we saw 7 great conversations get started on the Odyssey forums, and I want us to be able to, for those who missed it, know what's been going on, and for those who've been engaged, to be able to continue to engage in the conversation. So for those that have not been following, why the heck not? Shame on you. The Phenotype February has been our community activity that we kicked off on February 1st. We are now on 2/22/2022, which means we've made it through 21 days thus far, and we're on our 22nd day of taking a given phenotype every day and starting a community conversation about what is the clinical idea that we're targeting and what is the phenotype that we need to develop to study it. So we've kicked off now 21 different conversations that have led us to great conversations, both on how do we actually create a phenotype that can be used for a particular question, but also getting into some of the fundamental scientific issues about how we actually go through the phenotype development and evaluation process. Craig already posted that if you haven't kept up with all the conversations yet, you can see one-stop shop at odyssey.org/phenotype February, which is providing the links each time we start one of these conversations. To reinforce the idea that these are the starts of conversations that we hope that everybody will engage in and continue on. So if you missed a day, you haven't missed anything. Please just go read the discussion and join in the conversation. And it's fun to see so many parallel conversations going on, and I hope that more will join in and engage in this. How can you get involved? So everything's happening out on our Odyssey forums at forums.odyssey.org. For those of you who are in our Odyssey Teams environment and wondering, like, where is it there? Craig's been posting on the general channel just to provide you links out. But we purposely chose to put it out on the Odyssey forums because that information is being indexed by Google and hopefully will become valuable resources as people are using this in the external environment more broadly. So encourage you to go out to forums.odyssey to read and post and respond. Really, the way to get involved is read and respond. That's what we're looking for. For those of you who have have access to data, you can also evaluate definitions by running the definitions that have been shared on your data and sharing it. We've been making the cohort definitions that have been developed in Atlas. We've made them accessible on a public Atlas-phenotype instance. And we are also making available results of evaluations on selected databases out on data.odyssey.org. We have now volunteers for all 28 days in February, so thank you all who have led and decided to engage in the conversation. It's great to see so many people participating. But if you feel left out and you want to lead a conversation, there's nothing to say that we can only do 28 phenotypes in Phenotype February. Feel free to engage and join another conversation and lead your own. And hopefully phenotyping won't stop in the month of February, but hopefully this is really just a kickstart, an activity that we all should engage in throughout the rest of our research. Highlighting, reinforcing again, if you're looking for phenotypes that we've created, most of them have been posted out at atlas-phenotype.odyssey.org, and you can check that out. You can get access to that. Those that have been run on selected databases and results have been shared have been posted at data.odyssey.org/phenotype February. So if you're looking to see cohort diagnostics in action, you can see it there. And for those of you who'd like to run this study, you can go out to github.com/odyssey-studies/phenotype February. And Gautam Rao and Ozzie have been leading our phenotype development evaluation work group. They had another session just last week, and we'll continue to provide support for those that are interested in engaging in these activities. So where are we at? We are now in week 3 of Phenotype February, which means you're going to get to hear today about acute myocardial infarction, heart failure, cardiomyopathy, multiple sclerosis, triple-negative breast cancer, multiple pulmonary hypertension, and prostate cancer as the areas that we initiated conversations just this week on. So I have a special thank you to Gautam, Ozzie, Adam, Evan, and Asia, who've initiated these discussions and are here to share some of their fun facts. We have the rest of the month already outlined, and I'll highlight that in just a second. But I want to right now focus on these specific discussions that we've initiated for these various diseases and ask those that have led those conversations to share their insights and fun facts. While we do that, we're going to post again a link out to pollev.com/PatrickRyan800. I think Craig's going to just paste that link in the chat for those of you who don't see it. But we want to hear from all of you about fun Phenotype February fun facts you've heard so far. And so we started this last week, getting folks to share some of their insights. You'll see that those insights and lessons learned are still there in the chat. But as you've been reflecting on what you've learned from the past 21 days of conversations about phenotyping, it would be great for you to post in your own insights. Or if you see something that sounds good and interesting, feel free to upvote it in this list. And so please do go share your insights, and we'll go look at that in just a few minutes. So I'm going to turn it over to all of our leads for this week. Ask them to just share a brief insight about the phenotype that they initiated and a key fun fact that they discovered. I'll start here with Gautam from day 15, acute myocardial infarction.
Oh, this phenotype has given me a lot of chest pain. It is difficult. It is difficult. The work is not done, so I think I'm going to continue to work on this. It's very interesting for me that some of these phenotypes, even though there's been a lot of scientific work done, I found that there is no good code definitions out there that we can use. So there's a lot of opportunity to build on, and that's just my insight that I wanted to share. So please, for this particular one, please join us at the Phenotype Development Evaluation Work Group. I'd like to use the work group's time to collaboratively develop these clinical ideas and have some robust core definitions.
Very good. Thank you, Gautam. Yeah, and I think specifically the thing that I think Gautam tried to do a nice job here on the forums is highlighting the different subtypes of MI and asking the question, to what extent do we think that those subtypes are relevant in something that we need to be phenotyping specifically? There's tons of literature showing how people have defined MI at large, but I think Gautam's asking the tough question about whether or not we need to be able to do better by being more specific for the subtypes that can be represented for this clinical idea. Then Gautam, you started a conversation on heart failure on day 16. Share insights and fun facts there.
Same general idea. Again, this one has given me shortness of breath. So please, this is an opportunity to further evolve this clinical idea. I have lots more work to do on this one.
Yeah, so for those of you who have done prior work in heart failure, it would really be great to particularly get insights here on the clinical definition of what we're targeting. There's constellations of different diseases that are represented here in heart failure, and I think as we've seen past studies done, very often heart failure is used as kind of a crude proxy of something else, particularly if we think about like a hard outcome being something like heart failure related hospitalization, which is more of an acute episodic event versus the chronic disease status of heart failure that is sometimes what we want to represent. So having others join in and thinking about how we collectively can develop a phenotype for you would be quite helpful. And then Gautam, and ending up your 4-day run of cardiovascular diseases, you try to tackle cardiomyopathy. You want to share insights and fun facts there?
Yeah, so my understanding of cardiomyopathy is the cardiomyopathy has not been cardiomyopathy the way we think about it in the past. So that the contemporary definitions of cardiomyopathy is different from historical definitions of cardiomyopathy. And that's important because these days, in the last few years, we have the hypertrophic cardiomyopathy, restrictive cardiomyopathy, and the dilated cardiomyopathy. But in the past, there has been various other subtypes. Plus, what we learned is even though there is certain clinical ideas described in practice, it's not. It's the people when the clinicians call somebody to have cardiomyopathy, they don't mean the same thing. For example, ischemic cardiomyopathy. In some contexts, ischemic cardiomyopathy is not considered cardiomyopathy, and so on and so forth. So there's a lot of variables here, and the biggest insight for me is this is not a one-day activity. This is the beginning of the story.
Good. Yeah, I think in this one of the things that Gautam shared that I thought was interesting is he fixated on talking about all the different subtypes, and then we looked at the data, and 70% of the records we have are just coded at the non-specific level of cardiomyopathy. So thinking about how we reconcile clinical precision with the broad strokes of what actually exists in data can be an interesting challenge for us to think about, not just for this specific cardiomyopathy example, but as a broad problem that we need to think about for many different phenotypes. All right, And then Ozzie stole Gautam's account and prevented him from posting something and started a different conversation on day 18 about multiple sclerosis. Ozzie, can you share your insights and fun facts from that?
Yeah, I think I got two insights after working or starting the conversation on multiple sclerosis. One is that multiple sclerosis, like some other disease, is a disease that can start and then either go into remission or can have relapse. So it goes in different stages for different patients. And when we try to phenotype, one question we might want to answer is what kind of multiple sclerosis patient we are modeling, but at least think that there might be more than one model, and which is that one that represents the disease itself for the most part. An initial onset of multiple sclerosis is one kind of patient. A patient with multiple sclerosis in remission is another. Patient in multiple sclerosis with relapse is another kind of patient. So these are things that might manifest differently in the data. In some cases, we have codes that can indicate something versus the other. In many cases, we don't, and we have to rely on some logic and so forth. So that kind of thinking is something that I realize in multiple sclerosis that is important to kind of understand these situations. The other insight is multiple sclerosis. There's a lot of literature that talks about the no specificity of observational definitions for multiple sclerosis, or like the claims of the codes used for claims might have no specificity because the disease takes long to be diagnosed, and so the code might be used for ruling out purposes. And what I learned is that there is this general idea about codes in observational data having no specificity. However, it's really not one situation that covers everything. It's not the same for diabetes. It's not the same. Like, we really don't need to understand the specific situation we're dealing with and not have one rule that goes for all codes have no specificity, or all codes have no specificity. You have to understand literature can be helpful in this situation. But the more important part of this, my insight was there are different approaches to improve specificity of a definition, and there is no one solution that can work for all the situations. So in the US literature, there's a lot of this idea of using multiple diagnosis codes to improve the specificity. But if you take it and apply this across all data sources, you might actually get to worse situations. So really to think that what an approach to improve specificity for one disease in one data source at some point in time is not true for another database at some other time and for other circumstances. So think about this very thoroughly when you're starting to do this.
Very good. I'd say don't just think about it, empirically test it, rather than making assumptions. So all of you out there who were just told in your intro to database informatic class to just do 2 or more diagnosis or one in an inpatient setting, we need to brainwash you from that silly rule, because it is not a one-size-fits-all at all. Very good. Thank you, Ozzie. Day 19, Adam took the reins and initiated a conversation on triple-negative breast cancer. Adam, what were your insights and fun facts from that?
Yeah, so my fun fact is don't use the concept for triple-negative breast cancer to find triple-negative breast cancer only. Although it basically, my cancer is difficult, and I had a lot of similar thoughts to what Ozzie was just mentioning, that you really need access to the data and be able to test your cohort definition. Is really tied up with the type of data you have and the vocabulary as well. What measurements what measurements were used to capture the ER negative status, PR negative status, and HER2 negative status. So yeah, I think I've just scratched the surface with this one. And I think for cancer, some of the discussions I had with ICEA are we look for an index on a condition, and then also look for like a biopsy or a measurement within some range of that to try and get a good index for cancer. But yeah, I learned a lot, and thank you.
Thanks, Adam. I think you did a great job of actually showing a nice demonstration of creative ways to think about that trade-off of sensitivity and specificity when using multiple measurement markers for the estrogen receptor, progesterone receptor, and ER2 receptor. You showed how you could either think about requiring that you observe them to be negative, or requiring that you can't observe them to be positive, or what happens if you don't do it at all. And I think that that's a nice rubric to think about when you need to integrate a broad diagnosis, in this case of all breast cancers, with additional information to help us get more down into the specific subtype. So encourage people to join Adam in the conversation of triple negative breast cancer here.
Hey, Adam, this is Thomas. How many of the patients in your cohort had the measurements? So it seems like the two conditions were a condition and a biopsy. How many of those patients actually had indications of measurements?
Well, I only had really limited data to look at this, so I don't have the number off the top of my head, but it was smaller. It was, it dramatically reduced the cohort size to require those measurements, especially the measurement values. So that's why I went the other direction of just requiring that they had a measurement and did not have a positive measurement, as well as had no drugs that indicated that they were ER positive or estrogen receptor positive. So it had a big impact, yeah.
All right, day 20, we got to the weekend, and Evan started us off on a conversation, finally putting the pH in Phenotype February with a discussion, a very extensive clinical description of pulmonary hypertension. Evan, as you went through this, please share any insights and fun facts that you came across.
Well, I think it just came across there. I just put in a link that demonstrated demonstrates the classification of pulmonary hypertension that actually the WHO has maintained or created some really meaningful distinctions that are often used at the bedside. And one of the things I found kind of fascinating, this is a bit of a prelude to the discussion that's going to be coming, is if you actually look at the ICD, the most recent version, ICD-10 that's in deployment, those distinctions that are really maintained by the WHO don't quite make it into the terminology. And I thought that was quite interesting. It's not in every disease where you see the WHO using a class, have to create a classification system that's used at the bedside, and it kind of highlights the constraints that the terminology is under in terms of its evolution to incorporate, the cutting edge distinctions within a particular disease. And I think Claire last week mentioned the constraints that the CDM is under sometimes in terms of how it evolves. You can imagine how much harder that is, in a system where your main vehicle for counting things is the terminology itself. It winds up being fairly constrained in terms of the way it evolves. So I thought that was an interesting fact. And one of the things that it led me to start thinking about more is just the need for broader feature generation. And Paul, I feel bad. I didn't go into the different imaging characteristics you can see, but they're certainly there. I know. And as a card-carrying medical physicist, I feel a lot of shame right now. But there, I think the potential for things in imaging, echocardiography, which often has very structured reports that could be really amenable to feature generation, EKG. I think there'd be a lot of interesting things that we could look at because the source terminologies are going to be a bit challenging in this space.
That's very, very, and I think Evan, your highlight about the fact that the coding designation doesn't actually meet up with the subtypes is also part of the generic explanation for why we see subtypes of diseases get coded at higher level constructs, is because if you're only left with the incompatible constructs, you kind of have to pick the thing that's non-specific just to represent the idea that you have in your head. And we see that play out in a lot of situations where, in hindsight, we look back at the data and start wondering, why did clinicians code it this way? And you're pointing out, maybe because that's actually the best and most appropriate thing that could be done given the constraints that existed in the system.
It also shows what a massive asset the terminology effort is in OHDSI, I think, because in looking at those, and that's another prelude, is that there's a much better alignment with those clinical ideas, and just as more systems, I think, kind of realize the power of the terminologies to help them, manage those changes in the underlying source vocabulary. I think they'll see what a gift that is to the medical informatics community as a whole.
Very good. All right, so certainly encourage you to join Evan in the journey on pulmonary hypertension. Then just yesterday, day 21, Ozzie started us on a discussion of phenotyping prostate cancer, and both sharing some of the work that had been previously done within the IMI Pioneer project, but also exposing some new insights. Cassie, you want to share some insights and fun facts with the group?
Sure. So I'm just going to put them together. I think, like, generally when I'm thinking about it, it's never getting boring. And the more you do it, the more you learn about all these nuances and details. Some of them, like Adam's talked about, that you have to consider. And so, like, day one of the conversation, it was one question, and now, like, there's a list of questions that we have to think about. And the more you do, the more questions you know, and the better you get to understand the difficulty and all the challenges that phenotyping has. But I think that's not possible with the power of the community. Like, everything that we can get from the clinical expertise and experience, from all the insight that we can learn from the databases and the expertise of the data, like, and the vocabulary and everything that is the only way to make it possible, which kind of highlights the importance of clear description of a specific phenotype, which is pretty much lacking in the literature. But on the other side, the other good part was don't forget about the data, the power of the data, and how we can do some empirical assessment. I had a lot of fun, but I had to stop at some point not to get too much into that. Yeah, and then let's make it better. I don't think we're done there.
Very good. Yeah, Ozzie did a really nice example of how you can actually let the data tell you about co-occurrence of elements to give you an empirical basis to make some of the decisions that all too often we see kind of get arbitrarily made by someone saying, oh, it's a 30-day window, instead of actually looking at what the data actually tell us should be the window, which I think is a really powerful tool that we all can take advantage of. So if you're interested in prostate cancer, please join Ozzie in this conversation that just kicked off yesterday. So just to give you a sneak preview of what's coming up for the rest of the week, you're going to get to learn about HIV, hidradenitis suppurativa, anaphylaxis, depression, non-small cell lung cancer, drug-induced liver injury, and developmental disabilities, plus any other conversations that you all want to kick off during Phenotype February. I encourage you to do that, to join any of these 28 conversations as they kick off, or initiate your own. The main thing that we're trying to do is, one, hopefully get to the point where we've got some phenotypes we can trust for these diseases, but also try to make sure that we're evolving the science of how to do phenotype development evaluation and start to evolve towards having recommended practices that we can all follow to do a better job of creating more important, or more evaluated and potentially valid definitions. So I'm going to switch over to our pollev.com/PatrickRyan800. Encourage you all to be entering stuff in. I'm going to see if I can drag it over to the screen, and let's see what you guys.
Cool. So I think then the later was more for a, can everyone hear? Always good, right? We're still being recorded. Let me stop sharing. So that was kind of for the phenotype report 3, kind of, so we have a few disease, one of them being MS. That's one of our study of interest for this year. So do we have any questions from the audience before we go to the last report we have for the remaining disease? Cool. So with that, I will start sharing for the report number 4.
For a very successful Phenotype February. We've been able to successfully, as a community, go 28 days and stimulate conversations and provide important progress on phenotypes, 28 phenotypes in 28 days. Reminder that what our goal was really just to try to engage our community in thinking about the science of phenotype development and evaluation. And we tried to do that by identifying 28 priorities that we could go after and learn about how we could share insights, develop solutions, and learn from each other about the process of developing, evaluating phenotypes. Craig created this website, odyssey.org/phenotype February. For those who haven't been able to keep tabs of all of the conversations, I encourage you to take a look at the list of those phenotypes. But what I want to highlight is there is not just 28 days to Phenotype February. We actually had 29 days of Phenotype February. And this week, we're going to be able to showcase the work that's been done over the last 7 days within our community. And then we will take time in subsequent meetings to really kind of take an overall reflection of what's been accomplished. But I want to thank specifically Rupa, Jill, Erica, Tiffany, Juan, Asia, Anna, Claudia, Marcella, David, for their contributions this week. And we'd like to actually take a moment to hear the fun facts from Phenotype February from each of these conversations that have been started on the diseases of HIV, hidradenitis suppurativa, anaphylaxis, depression, non-small cell lung cancer, drug-induced liver injury, developmental disabilities, and vision impairment, and acute kidney injury. So without further ado, I'm going to actually I'm going to ask those who led conversations this week and started some conversations if you all could share your fun facts, starting with Roomba.
Sure. So this was a phenotype I had worked on a while ago and then now came back to it. And even through this celebration of Phenotype February, I learned so much more. I'd say one of my big takeaways is really thinking about how Phebvaluator can help. If everyone, I'll give a high level overview here. For HIV, there's a lot we can learn about using the diagnosis code, a laboratory measurement, and drugs. And we created a few cohorts to really explore all of these things. Some gave us some definitive answers on whether or not laboratory measures exist, how the drugs are being used. We had great conversation by Nige and others about how combination therapy can be used. A lot of people in our cohorts have comorbidities, but really at the end of the day, there were some key things that I think Phebvaluators sort of started to bring up to the surface, really around this idea of using a second diagnosis. How helpful is that? Pairing things with medication. So just wanted to give a highlight, a shout out for Phebvaluator. And that's the last thing I'd say is databases do matter. And I think I knew that going in, but how much they mattered really is visible through our evaluation, really looking at Medicaid, Medicare separately from a CCAE, which is really our commercially insured people who are employed, versus those that are getting aid from the government. I think it really starts to highlight some disparities that we see in this disease.
Very good. Thank you, Rupa. Day 23. Jill led a conversation. Jill, can you share your fun fact with the community?
Yeah, I mean, this work started out for me internally at J&J, and it was basically to build some phenotypes to load up our library. And I think some of the things that, internally, this is a pretty, active program. There's things happening. And what I learned is by posting on the OHDSI website or Phenotype February is that although we have a lot of clinical experts, we didn't get a lot of feedback on this phenotype, which I think sort of speaks to the fact that there really isn't a whole lot of knowledge known about this. So I feel like for me, one of the takeaways, not only about phenotyping, was just that I think there's a lot of room to contribute here. And I think that our observational data is well suited to do that. And having our really structured phenotype development process is really going to help authors to be able to reference that in future and kind of really provide a very a nice way to develop manuscripts around that and move the field forward. So I think that was my big takeaway.
Very good. Thank you, Jill. Day 24, we heard from Erica about anaphylaxis. Erica, could you share your fun fact?
Yes, and I'm representing both Ozzie and Marcel as well. And I think our fun fact is that I think maybe our story is a little bit different in that we had a well kind of thought out definition of anaphylaxis. So we were reusing that for the study where we're going to look at incidence rates of adverse events of special interest within COVID patients. And so we were using cohort diagnostics to review how well are these phenotypes performing in our data sets. And what we learned in looking at the IPSI data set is that there was a standard code that IPSI was using for anaphylaxis that wasn't part of our definition. And the reason why it wasn't part of the original definition is if you're using the OMOP vocabulary, there were no source codes that mapped to that specific standard concept ID, but IPSI does manual mapping. So it has their source codes, and then they kind of have to say which standard code. So that's how IPSI got there. And so I think my main takeaway is that even if you have a well thought out phenotype definition, even when you go through and do a study, it's still good and worth your time to review cohort diagnostics, because you may learn something new as data kind of changes over time, or if you have a new data partner, you might learn something about how well the phenotype might perform on that data. In this case, we were able to add that additional standard concept ID. It's not going to impact other data sets as much as it would impact a data set that does that standard source code to standard concept ID mapping. So.
Very good. Thank you, Erica. And on day 25, we heard from Tiffany, Juan, and Bill about depression. Tiffany, can you highlight your fun fact?
Absolutely. So aside from Juan and Bill making phenotyping extra fun, I think what we really learned from our post was that there can be great value in combining different types of phenotyping algorithms, not only to help you identify things you might not know that you're missing, but as a way to meaningfully adjust your assumptions or even recalibrate what you thought was a solid definition, not just only based on a specific population, but also based on the specific concepts that you're looking at with respect to that population. So by bringing in different methods that have different strengths, you result hopefully in a stronger phenotype, or at least identify things that you didn't know you should be capturing.
Very good. Thank you, Tiffany and team. And Ozzie took us into day 26 with non-small cell lung cancer.
So we started with a team that have done quite a lot of work in oncology, specifically non-small cell lung cancer, like trying to create phenotypes. So it's actually a very interesting discussion. Should we phenotype or not? And what is it that we're trying to phenotype? So the entire exercise was like a very good demonstration that the answer is it depends. To what is it that you're trying to get, the trade-off between the sensitivity and specificity, and like the impact of all the changes like within the treatment landscape and the clinical knowledge that can actually help. So we're still working on it, and the answer is still it depends. But I really want to actually thank everyone who worked and contributed to this. I learned a lot, and we'll keep the community updated.
Very good. Thank you, Ozzie. Then we had day 27. Anna initiated a conversation about drug-induced liver injury. Anna, can you share a fun fact?
I'm not sure how useful it would be, but it definitely is fun for me. So one day, Patrick mentioned that the Digley problem is largely unsolved. And I was like, yeah, we can add something useful here. And then I looked at the space and found this paper produced by Columbia DBMI. And when I saw 20 pages, that should have warned me that the problem is harder than I expected. And then I thought, okay, let's just implement this phenotype. And it was much harder than I thought, because essentially the acute liver injury codes are very much overlapping with the codes of the conditions of exclusion. So it was hard just to implement the concept sets. And then it was hard to implement the logic. And then I thought, okay, but at least we can review some charts and find some fun things in patient profiles. And then I saw 5,000 patients, and I didn't know how to approach them. And finally, when I selected a couple of patients for the chart reviews, I could not draw any conclusions from those charts that I selected, because it was so hard to make the decision of whether there were cases or not. So the fun fact is that it's really hard. And I guess we can contribute in this space a lot, given how hard it is.
Very good. Thank you, Anna. And I know this is an area that many folks have a high interest in. And so just because it's hard shouldn't deter us. And I see Judy has posted in the welcome to my world. Indeed, this is an area where I think we can solve that hard problem probably by collaborating together and just making incremental progress. All right, day 28, we had Claudia initiate a conversation about severe visual impairment and blindness. Claudia, are you on? Didn't see Claudia in our list. She might not have been able to make it. So I'll say that we were not deterred by the limitations of picking February. And I admire Marcella and David for initiating day 29 of Phenotype February. Marcella or David, are you on to talk about the initiated conversation about acute kidney injury?
Hello, Patrick. Yes, we're here. I think it was not only from us, but it was something proposed by the Phenotype February working group that we should not stop there. And also, I think one of the objectives of the group is to contribute with 2 more phenotypes. So we said we would volunteer for 1 more. And we started this with already some work that David has put together with preferences and a literature review on acute kidney injury. I think what I learned is that it was a lot more complex than I anticipated, this phenotype. And it was a learning experience. I think the most fun was to really discuss this with the community. I know that we just posted it today, but we started discussing this in the Phenotype work group, and we got very nice insights from Gautam, from Evan, Joel Swerdell, discussions also with Kevin Haynes and others. On the clinical definition and then on the implementation into Atlas. We also learned to work with the cohort diagnostics, and this is something that we would hopefully post later today. And Lee was supporting us with that. So it was, for us, it was a learning experience, and also going through the discussions and all the different posts from all the 28 previous phenotypes was very good. Someone mentioned it was a master class. It really was. And I think we should put this together. I think we've mentioned already that we should publish the learnings or the best practices in how to phenotype and continue with the talk and the discussions on how to make this scalable. I think this is very interesting and really a challenging exercise.
Very good. Thank you, Marcella and David.
Patrick, can you hear me?
Yep.
Oh, okay. I had to use my phone. My computer's microphone is not working.
Okay,
so
Claudia.
Claudia.
Yeah, can you share your fun fact from day 28?
Yeah. So one interesting thing that I found is that in terms of visual impairment, there are 2 charts that are commonly used to measure visual acuity. The Snellen chart, which was invented in the 1800s, and the ETDRS. Now, the Snellen has been shown to have less accuracy, but is commonly used. Even now, papers recommend it, just because it seems to be easier. So it seems to me that people want to do the easy thing, just because, instead of doing the most accurate thing. And that is a problem in terms of healthcare and everything else. So I thought that was interesting. And there are several papers demonstrating that the ETDRS charts are more accurate. But anyway, so that was interesting. And the other thing that I wanted to mention was that Gautam constantly mentioned that during the clinical, when we're working on the clinical description, we should not think about the codes. But I couldn't stop myself from doing that. And I kept hearing his voice, saying, now, stop, reset, start, which is what he wrote in his post. because, you know, constantly I kept thinking, can I do this? Can I really code this? Instead of just writing the clinical description. So there are some habits that I have to break out of to become a better phenotyper. So that's it.
Awesome. Thank you, Claudia. I want us to be able to break out in our sessions, but I want to again reinforce thank you to all of you who did engage in this Phenotype February activity. I think I'm extraordinarily proud of what we actually accomplished this month. We only started conversations of 28 different topics, but where else in the world would you actually find a community to come together and provide this much depth and scientific rigor, both to a wide array of clinical ideas across pretty much every disease area, as well as really focusing on the fundamental science of phenotype development and evaluation. I feel like as a community, you all helped us really advance the current status of where we're at as a field at large. And I do think that this is a great launching point for us to really try to mature the science of phenotyping for our community and for the broader scientific domain. So I want to thank all of you who led the conversations, encourage the rest of you to engage in all of these conversations that will continue. And for those of you who are thinking about doing the next phenotype, hopefully learn from the insights that have been shared from our community and take advantage of them as you continue your research.
All right, cool. So that is the last phenotype report we have from Patrick. Any questions or comments from the audience?
All right, so I put a link in the chat. I'm gonna try some.
Sorry, I just started again. So cool. So that's kind of what we have for today's community call, really kind of just we kind of started the Phenotype February about more than a month ago now, and now we do have 28 phenotypes that are ready. Although some of them are still have open discussions, I think that will really continue and really teach everybody how to kind of really scientifically how to use all of the tools such as Phoebe or Phevaluator for us to build the cohorts that we want for our studies. So before we end today's call, I want to do a quick preview of our next call in 2 weeks. So next, which is on March 24th. And then at that time, for that meeting, we'll invite Christian Reich from IQVIA OMAP, also one of the founders of OMAP. So he will be talking about the FIRE, not the FIRE and OMAP collaborations that we kind of discussed during last year's symposium, but we will also be inviting him back for another session kind of on the OMAP FIRE collaborations recently. Cool. Thank you everyone for joining us today, and I will see everyone hope I will see everyone in 2 weeks. Thank you.
Thank you.
Thank you.
Great.
Thanks, Jinling.